Hello, I'm Nafisatou Diop, and I manage the IMCHA, Innovating for Maternal and Child Health in Africa. Before we actually begin the webinar, I'm going to pass it over to my colleague Marie, who will tell you a little bit how to use this platform. Marie, take it.
Tips for a better experience during this webinar, and then I'll speak in French after. But first, our speakers will speak in French today, but the webinar is also available in English. So to have the English version, you can select your language. Please use the menu box in the lower left corner of your screen, as indicated on the picture here, and you can select English there. Donc, bonjour à tous, merci de vous joindre à nous aujourd'hui. Je vais maintenant poursuivre en français.
Morning, everybody. Thanks for being here. I'm going to continue in French. As you know, our speakers are going to be giving their presentation in French today. If you would rather listen in English, you can go down to the drop-down menu at the bottom left of your screen, as you see up here on my screen, and choose English. If you have any problems with audio, you can go to the configurations. So Robert from Kudo is with us. He'll help you if you have any problems. You can please talk to him. And also please note that this webinar is going to be taped. Okay, Nafi. Thank you, Marie. I'm very happy to be here hosting this webinar. Our team is going to present our work. Let me start by telling you a little bit about what IMCHA is. This is a partnership funded by 3 different Canadian partners: World Affairs Canada, Canadian Institutes of Health Research, and the International Development Research Centre. IMCHA started in 2014 and will end this year in July. Our initiative has funded 19 research teams that conducted a total of 28 research projects in 11 sub-Saharan African countries. IMCHA has also supported 2 HPROs to assist research teams in their capacity building and, most importantly, in knowledge transfer to integrate the research evidence into policies and programs. If you would like to learn more about IMCHA, you can visit the websites that we're showing you on the screen. I'd also like to share a few words about our presenters today. Professor Rosalie Diop has a PhD in sociology from Université du Québec in Montreal. She's a teacher and researcher at the Institute of Population Development and Reproductive Health at the Cheikh Anta Diop University in Dakar. Rosalie is also currently working as Director of Studies at that same institute, IPDSR. Rosalie is the principal investigator for the project, and she will be talking to you today. Dr. Samba Korassar is head of the research division at the Directorate of Planning, Research, and Statistics at the Senegalese Ministry of Health and Social Action. He is also permanent secretary at the National Ethics Committee for Health Research, and he's held that position since 2004. Dr. Sambakor is an associate researcher on the project we're going to discuss today. We could say much more about our esteemed colleagues, but without further ado, I would like to pass them the floor for their presentation. Rosalie, you have the floor. Thank you. Rosalie might be on mute. Go ahead, Rosalie, I can hear you. Thank you very much. Thank you, Nafisatou, for the floor. After that introduction, I can only say my name is Rosalie Diop. And today our presentation is going to talk about access to maternal and child healthcare access in Senegal. we're going to talk about how we've used Bajenu Gox, who are neighborhood aunties, if you will. I would like to extend a very warm welcome and a word of thanks to the IMCHA. You've just heard what they are, of course, the organization and its initiative innovating for maternal and child health in Africa. I would also like to thank all of our partners, the Institutes for Health Research in Canada, Global Affairs Canada, and the Institute for Development Research in Canada. I would also like to thank Nafissatou for all of her patience and unfailing support. I would also like to talk about how grateful we are to Dr. Ermel Johnson and Professor Sombier, who have done a lot to help us as well from the West African Health Organization. They have given us a tremendous amount of assistance and helped us in publishing articles. In Senegal, also, I would like to thank our Ministry of Health and Social Action, Dr. Sarr, Omar Sarr, who did a lot to help us as well. And he's also helped us pull into good shape all of the data about our research that we're planning to show you today. Dr. Amadou Doucouré has also been a great help as well. The doctor has also wanted to help see how we can use our results to improve mother and child health in Senegal. He has been keenly interested in all of our data and also did a lot to help us set up our workshop during which we were sharing the results. I don't want to go too far into my thanks, but I would also like to thank Dr. Oumar Samb, who was our co-principal investigator on the Canadian side. We also had associate researchers, Dr. Sambakor, who was a very effective, powerful, and present interface between the various parties who were conducting this research. And I would like to thank him very much for all of the help he did to help reinforce our capacities. And Dr. Atier, who is a physician who works with the NGO ACDEV, Action for Development. He has done a tremendous amount of work also to help us see this work through. I certainly couldn't end my thanks without saying that we've got a wonderfully dynamic team of young researchers. We've got our colleagues in Quebec who have worked on specific topics. We had a lot of young students who've been working on masters in family planning, in teen health, and what motivates teens in their health decisions. And I know that one of them was recently congratulated for the quality of their thesis, so I'd like to say great work to them. Ramatoulaye Dissou was our financial manager who also made big contributions. Many people played support roles right down to our drivers, and I thank all of them as well. Now, for the presentation itself, we have two different ways of approaching this. So, assuming our connections get us through, I'm going to give you some general background. And then Sombakor is going to talk about our strategies for capitalizing on and spreading the data. Now, as for the background, in Senegal, like in the rest of West Africa, maternal mortality is very high. It's still very high. In Senegal, you have 236 deaths for 100,000 live births. That's 4 deaths every 24 hours. For neonatal mortality, 23 for 1,000 live births. For post-neonatal mortality, 13.39 deaths for 1,000 live births. we're still far from our millennium development goals, which was to get down to 27. We also have a problem with childhood mortality, 36.8 deaths for 1,000 births. Same goes for young child mortality. And these are all generally related to problems around family planning, reproductive health, and the use of harmful traditional practices. The use of condoms is a bit below the goals that we'd set. 44.3% usage rate of condoms for women, 73.9% usage rate of condoms for men. As for HIV prevalence and the group of 15 to 24-year-olds, Senegal has been at these low levels for quite a long time. 0.1% for men, 0.3% for women. Very low, but still lower than where we should be for our MDGs. We also have the issue of FGM, and still prevalent in the Senegalese population. 23% of girls under 15 years old have unfortunately been subjected to female genital mutilation. We still have a very young age for first sexual encounters. As you can see, our numbers up here on the screen. 15.6% overall, 33.6% for women, 38% for men under age 18. Senegal has implemented a variety of plans and strategies to try to get the population more involved in maternal and child health. You can see the different plans appear. There are various 10-year plans. The PNDS is the Senegalese National Health Plan. The priority for Senegal was to improve reproductive health for the entire population. However, to reach good results in reproductive health, the country set out targets and was calling on civil society and community organizations to help achieve those results. And the government did reinforce those mechanisms to help improve maternal and child health. At the local level in communities, Senegal focused on a series of new strategies, the matrons, as they were called, the community health agents as well. There were also more local clinics and healthcare centers created to be closer to the population. The Senegalese government also created another new initiative to help the Senegalese population improve health outcomes. Some of these entities still exist, and we see them in rural areas. We have, for example, the community dispensaries of home healthcare and the matrons, also matron. Since 2009, Senegal has had this program called Bajenu Gox, and Bajenu Gox was meant to leverage female leadership and to further develop the community spirit in healthcare. For us, we think that the Bajenu Gox program is a great innovation and it's got a lot of value. First of all, it was created by ministerial decree. It was the president himself who pushed the creation of that program. And we thought it looked good from the get-go as an idea. So the idea of the Bajenu Gox is to take advantage of the honor, the prestige, the admiration, the recognition that are given to one's aunt, the father, the sister of one's father. In Senegalese culture, this woman plays a very important role in the popular imagination, in our common values. It's an endogenous concept, meaning it's very specific to the Senegalese cultural. So this is a great way to embrace the Senegalese culture and to leverage the role of these women for health. We looked at various subsegments of the Senegalese population and different cultures, and we saw that among the different ethnic groups in Senegal, we have different variations of the same role of this woman, the Bajenu Gox. You have Mbinki for the Manding and the Banyuk people. You have these women who are extremely important. You have the Bajen for the Serere, for example. And this is always a woman who's very influential, who's very closely listened to. And so we find that there's a long and rich semiological tradition for the Bajenu Gox or its equivalent, her equivalent, in the different cultural groups of Senegal. So this is a cultural concept that carries a lot of weight and that means a lot in our Senegalese conception of family and social roles. Why this project, Bajenu Gox? The president implemented this program and wanted to work through these community organizations that are already quite active and getting a lot done. The Bajenu Gox are very energetic and getting a lot done. But with the original Bajenu Gox program that was created in 2009 and formalized in 2010, it didn't give us all the results that we were expecting to see. And there are several reasons for that. First of all, community organizations, as is often the case, are volunteer workers who are often subject to fragile conditions. And Bajenu Gox were involved in a variety of projects already in their communities. And some of those projects are more financially lucrative than others. Now, it was decided by the government agency in charge of reproductive and maternal health that we needed to inject some new energy into the Bajenu Gox program. I don't want to call the program's shortcomings flaws, but I will simply say that the need was identified to revisit the program and to give it some more impact. There's the Bajenu Gox program, but then there's also a Bajenu Gox project. The Bajenu Gox program exists in virtually every region of Senegal, but then there's also our project, the Bajenu Gox project, which was really a study, a research program to see how we could reinforce the Bajenu Gox program. So the idea was to go beyond implementation of the program, go beyond preventive programs for maternal and childhood health. The idea was to see how could this program play its own role within a comprehensive health system. So here, as I'm saying, we wanted to re-energize the Bajenu Gox program. So the idea was to give a fresh start, get a jump start going in this Bajenu Gox program. So the main goal of our research was to study how a community development approach, developing synergy amongst the various actors, could reinforce the implementation of the Bajenu Gox program so that it could further advance mother and child health. So we wanted to see how can we give the Bajenu Gox, the women themselves, more tools and power to make an impact. We wanted to see what was the effect of the Bajenu Gox project on the Bajenu Gox ability to make a difference on maternal and child health. So we wanted to answer that question. We also wanted to look at the overall social relevance of the Bajenu Gox program, which is based on feminine leadership, women's leadership, but still molding itself to the socio-cultural context of Senegal. So to answer those questions, the 4 in the purple box, leading up to the one in the yellow box, which I just read for you, we worked in 4 different areas of Senegal. First of all, Guédiawaye, which is close to Dakar. So there were several Bajenu Gox based in that area. We also worked in rural areas. We worked in Fatigue at the Djaolé Health Center. 3 different neighborhoods, 11 villages with Bajenu Gox. Same for Kaolack. We were working with the L'Abattoir Health Center. 3 sub-neighborhoods and their Bajenu Gox. And then also we worked in the health district of Kébémer at the Ndandé post, 14 villages and 6 neighborhoods. We were trying to maintain a balance between urban areas and rural areas, which explains our choice of places to research. How did we implement our project? We worked with the ministry because this is always a participatory initiative. We worked with the ministry to help identify the areas. We also worked in particular with the Department of Maternal and Child Health. We also set up local steering committees, which is a local advisory body which helped establish the legitimacy of our research project and develop more support for our Bajenu Gox project, the BG project. They helped us interface with leaders in the community leaders and village leaders. They also helped us work through various centers on the ground. We conducted a feasibility study first to see what was really happening in those areas and to see whether we would be able to work there. We also trained the Bajenu Gox themselves to talk about the bouquet of services that they were offering. We wanted to really just reinforce the knowledge of the Bajenu Gox and make sure they were aware of what their tools were and perhaps introduce some new ideas that they could be using in their work. We organized workshops for these women, the Bajenu Gox, with some worksheets that they could use and some dialogues and speeches that they could use. We wanted to give them more tools to work with women who were pregnant, to help work with mothers of newborns, to educate about vaccination as well. And we wanted to give the Bajenu Gox the tools they needed to encourage women to visit health centers for their prenatal checks and with their newborns and to have their children vaccinated. So we also gave the Bajenu Gox, in addition to worksheets and new tools and scripts, we also gave them some tools they could use to oversee their home visits to visit with women. So we were implementing and researching at the same time because this was intervention research. So in terms of our research plan, here are some of our methodologies. We were working on the basis of participation with multiple iterations so that we could continue to leverage the results, put them into action, and continue our research. So it was a very inclusive and iterative process. It was important for us to let the communities take advantage of the scientific results of the research as they were becoming available. We also used some interview guides, we created some dialogues, and we were able to observe the ongoing changes in the use of these tools. We also made 3 videos, and they further document the processes that we were following. So what was the situation before the project began? I told you that we took stock of what was happening, and we made various observations. I mentioned this at the top. There are still some problems. There are still some lags. In particular, finding one, there's still violence of many kinds. Some of it is related to neglect. Some of it is abuse. In particular, it's targeted at children and girls. We still saw early marriage. We saw teen pregnancies and excision. So we were looking at what's missing, what kind of social initiatives or coaching needs to happen in order to fix some of those problems. We did see gender-based issues. We saw a lack of empowerment and lack of decision-making autonomy amongst women and girls, in particular for girls who are in reproductive age. We saw some shortcomings in child vaccinations. Some precautions are being taken in terms of decision making. Women have some latitude, but in general, the head of the household, the father, has to give his permission for many of these health initiatives in the family. We saw considerable economic fragility, which makes it difficult for some of the women to access health services. Sometimes it's 3 or 4 kilometers away, too far for them to walk. That was finding 2 was the economic factor. Finding 3, insufficient healthcare systems, also inconsistent use of family planning services, sometimes shortages of equipment and supplies. We also saw that not all pregnant women were completing their 4 recommended prenatal checks. Same thing for postnatal checks. And there also seems to be a lack in some cases of healthcare personnel. And finding 4, we saw that the Bajenu Gox themselves had very limited capacity and resources. These women are extremely dynamic, but they weren't very well trained in communication for social change. They didn't have all the skills they needed to provide the right information and couch their messages in the right way to promote reproductive health. And the Bajenu Gox also certainly have financial challenges of their own. So the Bajenu Gox also need to have some kind of income generating activity so that they can make a living and meet some of their own basic needs, so that they can actually go out into the world and do what we need from them and expect them to do. So one of the things we wanted to see was how to build more capacity, economic capacity for the Bajenu Gox. After that situational analysis, after taking stock of what was happening on the ground, we wanted to identify how we could restart the Bajenu Gox program. So one thing that we did was ask ourselves, what is the perfect profile for a Bajenu Gox? As we observe the work of the 63 Bajenu Gox that we worked with, we saw certain characteristics. we saw that the age of the Bajenu Gox and the number of children she has are two criteria that can be correlated with her success as a Bajenu Gox. It also influences how much personal experience and knowledge she has about motherhood and pregnancy and managing health problems in a household and managing social dynamics in a family. We also notice that if a Bajenu Gox is older, that means that her children are old enough to do some of the work in her house so that she is more able to go out and do health sensitization work in her community. So if we want the women to go out and help other women, they need to have the time to do it. So all of this makes sense because it was corroborated when we noted that 52.4% of the Bajenu Gox are over the age of 50, 77.8% of them are over the age of 40. There are a few who are between 25 and 30, but the majority of them, as you see, are older. We also saw that the marital status of the Bajenu Gox is a factor as well. 27 of the 63 Bajenu Gox with whom we worked are in polygamous households. 22 of them had fewer than 3 children. So what does this mean? A Bajenu Gox who has sister wives has more free time to go out and play a role in the community. It's easier for her to spend a half day outside of her household or away from her children. Those Bajenu Gox who are in polygamous households simply have more free time to go and do this kind of work. We also made an observation about the innate motivation of the Bajenu Gox because we were curious to know what motivates them to go and do this kind of work. What makes them want to be health advocates and health advisors? What gives them the desire to go do that? We notice that many of them feel a social calling. Some of them feel like they have a social debt to pay. Many women felt like they had to do it. It was their duty to do it. They felt like they needed to make a contribution to their community. This debt towards society meant that all of these women were already engaged in other civic actions and women's groups and women's associations and women's financial empowerment groups. Most of these women were already engaged in other organizations because they felt the need to be involved in their communities. And that was the case for 43 out of 63 of them. "22 of the 63 Bajenu Gox also held the official status of community health agent. Some of them were the matrons, and some of them were community coordinators that had been created through the national health system. We also see that these women, the Bajenu Gox, are seen as an interface between community health centers and the people living in the community, which gives them a very important role in the community and in public health. Now let's talk about mobilization. How did the Bajenu Gox go about getting communities involved? How do they get people involved? A lot of these women have rights, but have no decision-making power. These women don't have any financial autonomy. Sometimes it's young girls. And so when you're looking at the potential beneficiaries of healthcare services and healthcare advisory, we have to teach these women that they can negotiate with their households, negotiate with the people around them, with their husbands to make decisions. So the Bajenu Gox were there to strengthen and build confidence in these women. For young girls and women of reproductive age, they were educated about the importance of visiting health centers. So the first step was to build confidence and help these women understand how they could advocate for themselves. But then there are the guardians, the group of people who make the healthcare decisions. Sometimes it's a mother-in-law, sometimes it's a husband. The Bajenu Gox had to also work with those community members and family members. Those people have moral obligations in the social structure. And ultimately, they would make decisions about family planning and healthcare decisions. So for that group of people, they needed to be valorized as empowered. Those people who had certain obligations to the people with rights but no decision-making power.
Parfois demander aux hommes de les accompagner dans certaines discussions. On a eu quelques résultats sur là où, effectivement, il y avait des leaders hommes qui ont accompagné les Bajenu Gox quand il s'agissait des VAD, etc. Et juste noter qu'à ce niveau-là, les ICP, c'est-à-dire les infirmiers chefs de poste.
So this also included the midwives, because the midwives were often the ones who were setting the tone of the conversation, and they gave the Bajenu Gox even more credibility and power. So they were there to help the Bajenu Gox in the community and to continue helping them. And those were the topics that they found the most important to listen to. And it helped them talk about health and deliveries and healthy deliveries. So we went and we did this closer look to have a comparison with what was happening in 2016 versus what was happening in 2020, because we needed to get more recent data about maternal and neonatal health. So you can see some slightly different figures. So we have figures over 12 months for 2016, but only over 8 months for 2020. So the first item is women who went to their prenatal checks, their first prenatal visit, and we saw an increase. It's not entirely clear, but we do see that even more women went for all 4 prenatal checks. That's the second line item here. Then we also saw an increase in the number of deliveries in healthcare centers. That's item 3. And then there was also an increase in the number of deliveries that were attended by a qualified healthcare worker. Again, the first column, those figures are over 12 months. So for 2020, it's only 8 months. The numbers are already higher and they only cover a shorter period of time. So you can see the results for 2020 are certainly better. What are the project's impacts? If Dr. Sambakor is still here, he should take over now and talk about what we're doing to leverage this data internally and to talk about what we can do now to further empower the Bajenu Gox based on the results of our research. Nafi, is Sambakor with us? Yes, I'm here. Great. Thank you very much. Try to be brief so that we can leave some time for discussions. Is that okay? Okay, Sambako, go ahead. Thank you very much, Rosalie. Thank you to our attendees today at this webinar. I would like to tell you about the overall takeaways from this great work that was coordinated by the NGO AGDEV, because I think that they were able to help us influence the way these community organizations are working. And that was also with the backing of our Ministry of Health. There are now several Bajenu Gox associations that are formal, and they actually have signed healthcare service contracts with health development committees. We have also seen now the organization of regular training sessions on neonatal and child and maternal health. We have seen the integration of the Bajenu Gox associations in the healthcare system. We've also seen some funding for income generating activities for the Bajenu Gox. We saw a visible role played by the Bajenu Gox in fighting COVID-19. And we've seen the Bajenu Gox involved in all of the programs that have been set up here and there to help and improve their financial capacity. And there are also mobile mechanisms that exist now to go out into the communities. Those are all some takeaways that we've seen. Next slide, please. Go ahead, Somako. Here's another important aspect of this project. We need to assess our ability to capitalize on these learnings and scale them up. The key message, well, we have several of them, but one big message for us is that the Bajenu Gox work does increase the use of maternal, neonatal, and child healthcare services. The role of the Bajenu Gox does result in increased rate of vaccination. It also results in better nutrition for children and a higher rate of use of family planning and prenatal health check services. We wanted to distill those key messages into objectives. So we had 3 objectives that we defined. One is share the research results. Objective 2, promote behaviors that improve teen, child, and maternal health. And 3, we wanted to provide more detailed information to scale up the project to the program level. We noted that it would be important in providing that information to create truly actionable, easily understandable information. Next slide, please. Still on the notion of capitalizing on our resources, the speaker can no longer be heard. Notes the interpreter. Sambako, are you there? Yes, so here we're looking at the participation of decision makers in designing and implementing research. You can hear me now? Yes. Also, share results with the community, share results with programs that might want to use the Bajenu Gox as vectors to share information or practices, share these results with strategic and operational decision makers, identify specific learnings that can be implemented as part of an inclusive approach. Also, write and share policy briefs around the topics that we will have identified. And then we want to further mobilize Bajenu Gox in anti-COVID-19 efforts. Next slide. In conclusion, although we've seen a heightened rate of deaths in Senegal, 2,036 deaths for 100,000 live births is hard. And by 2030, the SDG is 70 deaths for 100,000 live births. And then for 2030, we have the SDG of 12 deaths for live births, whereas we're currently at 23. And we need strategic plans that take into account all of the evidence that was derived from our research. The Bajenu Gox associations need more capacity. Let's hope that he will come back in a few minutes. Oh, here he is. Thanks to this project, we were able to further formalize the skills of the Bajenu Gox, and more Bajenu Gox associations were created. We also saw more funding for income generating activities, and we saw that income generating activities further motivates the Bajenu Gox to get involved, and it makes them not only more willing, but more able to play a role in social change. We also want to use income generating activities to create more social health spaces in the communities. And finally, we need to develop more income generating activities to fund the work of the Bajenu Gox associations. And for my final slide, we want to thank all of you, because we have demonstrated that decision makers, researchers, grassroots community organizations, and NGOs who are active in promoting community health can work together to build the body of knowledge, and we can bring the health system forward, and we can make progress on the indicators. You have 3 photos in front of you that show you our participatory research program in action. You can see administrative work, you can see sensitization work, and you can see some of the Bajenu Gox that we think were re-energized by our work. I think that Sambakor has some connectivity problems, but he did make it to the end of his presentation. Thank you to both of the presenters. Now we can go to Q&A. Sambakor lost his connection. Hopefully he'll be able to join us again. So please, if you have questions, I encourage you to type them into the messaging. You'll see it in the top right. You can ask any questions you have. And until we hear your questions, I might get us started with a question of my own. I know that Rosalie in her presentation already started to talk about the role of the Bajenu Gox. We understand that they have a role to play vis-a-vis women and encouraging them to access health services. Rosalie also started mentioning the role of men. And I would like Rosalie to talk a little bit about gender issues, because gender doesn't just mean women, gender means men and women. So who would like to answer my question about the role of men, Sambako or Rosalie, while others formulate their questions? While I'm waiting for Sambako, here's what I would say. It's true that Bajenu Gox work more with women and teens. They didn't have a lot of contact with men, which was somewhat limiting in the relationships that they could have. The Bajenu Gox in particular weren't able to talk a lot with teen boys, and this is something that we will need to fix in future projects. But for the husbands and for male leaders in the community, Bajenu Gox could access them for awareness raising and education, but they weren't necessarily targeted as men who were leaders in their villages. I have another question. Thank you for that answer. And it's about how to use research evidence for policy. So IMCHA wants to influence policy. So can you tell us more about the importance of your co-researchers? Maybe it was Dr. Saar in the beginning. Could you tell us the role of the policy decision makers and the role of your co-researchers on your team, especially those representing policy? We have some questions for you in the chat box, so let's make it snappy. Rosalie? Sambako? I think the great innovation for this project was the participation of decision makers in designing the research project. We created a link with the decision makers, the policy makers, which made it easier for the researchers to really put their finger on the problem. And that made it possible for us to transform the policy problem into a research question. And then policymakers could help us identify the methodology. And then, of course, the decision makers or the policymakers were able to put their weight behind implementation because they have bought into the process. Sometimes you have the problem of remove, but here with policymakers involved as sources of input in the research program, they are much more engaged in the transformation that we're trying to make happen. This way of working has actually inspired others in the Ministry of Health now. For nearly every different directorate, you have operational research projects with the same team, where researchers and policymakers together are organizing their research projects to transform the way they go about improving health programs. Thank you very much. We have 4 minutes left. Marie, do we have any questions in the chat? Yes, the first question is, how do you manage the money that's generated through these income generating activities? Who would like to answer that? Unfortunately, Dr. Et is not online to answer that question, and it is an important question. In the different areas, we look to see what the predominant income generating activity of the women was. Most of these women were small scale merchants. when we got the money, we wanted to see how to re-energize these women. So of course we were looking at training and their role as Bajenu Gox, but then of course we were looking at economic opportunities as well. And in each location, the women banded together to identify the best activities, and they were working with the NGO Active, and each of the Bajenu Gox associations was able to develop its own income generating activity. For some, it was husbandry. For others, it was commerce. This is an important point. I can cite the example of the group at Kaulak, and those women are actually processing grains. And those grains have high nutritional value that can also further their goal of improving child nutrition. The women are also working on iodized salt, which can also address a problem of lack of iodine in the diet in that area. That has consequences on childhood and disease, and so on and so forth. I'm sure we'll be able to talk about this on another occasion. But Active is working with the women to help them manage the money, and especially if they get into more advanced income generating activities like processing foods. Thank you. Unfortunately, we're out of time. If you have to leave us now, please, by all means, don't be shy. If you need to leave, please go ahead. If anybody can stick around, we can answer the questions that are still in the chat. I'm going to ask for very concise answers so that we can hear as many questions as possible. I know that we're so embedded in our project that we have so much we'd like to share. Unfortunately, it's just not possible. So is there another question? Here's the next question. It was asked in English. I'm going to translate that quickly. Sambako. I think we've lost Sambako again. Rosalie. Oh no, here he's back. Hello. Go ahead, Sambako. First, remember the areas were chosen deliberately. They were meant to be a representative sample. And these also were locations that had structures and data available. That means that we had indicators on record for all of those areas. So we collected all of the indicators at the end of the project. Okay, thank you. My next question, Marie. So you just mentioned those 4 regions again. Why did you choose those 4 regions? Is it because the Bajenu Gox were active there? Or was it because they actually were flagging in their efforts and you needed to inject some more energy? No, it was really to give them a jump start. It was a model that we wanted to test. We wanted to find some techniques that we could scale up. We looked at the national level and really found the same level of activity and prestige for the Bajenu Gox. We wanted to see how we could work with the Bajenu Gox in this project to improve indicators. So we gave them more capacity, more ability. so that we could identify the best practices to scale up by extending it to other regions. Marie, I'm sure there are lots of questions because people are very interested. So is age a determining factor in profiles of the Bajenu Gox? I know that you mentioned it. Again, Marie? In determining the Bajenu Gox profile, is age a determining factor? Yes, absolutely. Age is decisive. In our collective imagination, the Bajenu Gox is a very elderly person. They are indeed older. Age certainly dictates experience. The Bajenu Gox know more about women's health. They've had more experience with life, with mediation, with social communications. And then another important criterion is, as we already mentioned, that these Bajenu Gox have more free time because they no longer have young children. So it's also a determining factor because the older a woman is, the more time she has to devote to Bajenu Gox duties. Next question, Marie. Thank you. Is there are there similar initiatives to Bajenu Gox in other Western African countries? Sombako or Rosalie? Is there something like Bajenu Gox in other places in West Africa? Yes, Benin has the same initiative, and Burkina Faso as well. I'm sure a colleague could also comment on this. There are women leaders who play very important political roles in their regions, and the government often works with those women I know that's the case in Benin and in Burkina Faso. Do they use those women as vectors for promoting public health? Because you mentioned political issues, but Bajenu Gox, it's not for politics, it's for policy, it's for healthcare policy. So what you just described, is it only for political issues? No, it's for public policy, so it's for education, it's for agriculture, it's for health, public policies in the plural. Rosalie, did you want to add anything about that, or can we go to another question? We can keep going, but it's so important because the team from IMCHA asked a lot of questions about the case of the Bajenu Gox, and even colleagues in Mali have reached out to us to find out how it's been going. We really are sparking imitators. Marie? We still have 3 questions from the same person, so I'm going to ask all 3 together. They were in English. I will translate them in a moment into French. I would say that for this particular project, the Bajenu Gox were working throughout their zone. According to our results for Fatick and Kaolack, the results were very promising. The Bajenu Gox were in much greater touch with the population. But it all depends on the issue that you're tackling. For family planning, Bajenu Gox worked with women and men, so women and their husbands, so 2 target groups. In other areas, the Bajenu Gox worked only with teens. And as we mentioned at the top of the hour, someone even did a thesis on that project. But I would see on the whole, the Bajenu Gox worked essentially with women of reproductive age. I will clarify the question a bit. How much coverage did one Bajenu Gox have in terms of people? Usually we see one Bajenu Gox for 1,000 people, and with Active, we saw that Bajenu Gox couldn't get it all done, so we actually needed to recruit new Bajenu Gox in consultation with the ministry to provide better coverage. And when a Bajenu Gox works, does she work with a group of women? Does she meet with women individually, one at a time? How does she work? How does she communicate with the population? How does it go? The Bajenu Gox have chats with groups of women of reproductive age in the health outposts or in health centers. Usually the chief nurse or midwife from the health outpost would also be there with the Bajenu Gox. And in some places, the Bajenu Gox will go door to door. For family planning or for vaccination, the Bajenu Gox work with a couple, the woman and her husband. Usually that's how it goes. So they work with the community. It's quite accurate to say. Marie, are there other questions? Nope, that was all. No more questions in the chat. Well, we've already gone over by 10 minutes. I'd like to thank everyone who stayed on a little bit longer. Thanks to all of you. Thanks to everyone. Thanks to my team. Thanks to our participants. Thank you for the dialogue. I hope that we'll hear more about this project. And we know that the project will continue. We hope to hear more great things from you in the future. And good morning, good afternoon, good evening, good night, wherever you are in the world, and keep up the great work, everybody.